Welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for joining us today for Microbial Modulation, Exploring the Gut's Role in Antimicrobial Resistance, a non-CMA program of our Dr. John G. Bartlett Memorial Education Series. And special thanks to our webinar sponsor, Series Therapeutics. Before getting started, a few housekeeping matters. This webinar is being recorded and will be available on demand if you can't stay for the entire presentation. A link will be emailed to all registrants within 3 business days, or you can access it and share it via our website and the IDSA Foundation YouTube channel. You'll notice that your microphones are muted, but please use the Q&A feature to ask questions during the event. There will be a dedicated Q&A session at the end of the presentations. If we can't get to all of the questions during the Q&A, we will do our best to address them in a follow-up email. Now let's begin by reviewing the learning objectives. Our esteemed presenters will review the current challenges posed by AMR and the associated clinical and public health impacts. They will also examine the ongoing research in preventing and reducing AMR, explore the role of the gut microbiome in health and disease, and evaluate the underlying mechanisms by which the gut microbiome influences AMR. Finally, we'll identify potential therapeutic and preventive measures that harness gut microbiome modulation to combat AMR. And with that, it is my pleasure to introduce Dr. Mary Hayden. Dr. Hayden is the James Lowenstein Professor of Medicine and a Professor of Pathology in Rush Medical College. She is also Director of the Division of Infectious Diseases and Director of the Division of Clinical Microbiology at Rush University Medical Center in Chicago, Illinois. Dr. Hayden has served as U.S. Federal Public Health Advisory Committees, including the CDC Healthcare Infection Control and Prevention Advisory Committee, and the Board of Scientific Counselors for the CDC Office of Infectious Diseases. Dr. Hayden is a Fellow of the Society of Healthcare Epidemiology of America, SHEA, and a Fellow of the Infectious Diseases Society of America. She was the 2021 President of the Board of Trustees of SHEA, past Chair of the IDSA Diagnostics Committee, and she is current Chair of the IDSA Rapid Guidance on SARS-CoV-2 Diagnostics Expert Panel. Dr. Hayden, it's an honor to have you present today.
Thanks very much, Diane, and welcome, everyone. Could I have the first slide? Thanks. So my charge today is to sort of tee up the topic, I think. So to review some of the challenges posed by AMR and associated clinical and public health impacts, as well as examine some of the ongoing non-microbiome related research that is aimed at preventing AMR. Next slide. But before we talk about antibiotic resistance, I think we need to talk about antibiotics and to really acknowledge how remarkable these drugs are. So the development of antibiotics was one of the greatest public health achievements of the 20th century. I don't think that's an overstatement. This graph shows you the crude death rate for infectious diseases in the United States between 1900 and 1996. And you can see that the death rate at the beginning of the century in 1900 was 800 per 100,000 persons per year. And the most common infections causing mortality at that time were pneumonia, diarrheal diseases, and tuberculosis. And almost a third of those deaths were in children under the age of 5. So you can see that over the next 37 years or so, there was a pretty steady decline in ID-related deaths, except of course the peak that we see during the 1918 influenza pandemic. But this decline in infectious disease mortality really accelerated between about 1938 and 1952. And that was the period during which the first antibiotics were released. So first sulfonamides and streptomycin, and later penicillin. And while we can't say with certainty the relative impact of antibiotics on these declines in infectious disease deaths, they were likely to be substantial. And the next slide shows you some rationale for that. So this shows you antibiotic-mediated mortality reductions for selected infections. So you can see that In the pre-antibiotic era, community-acquired pneumonia had a mortality rate of about 23%, down to 7% with antibiotics. Nosocomial pneumonia had an even higher mortality and an even greater change in mortality with antibiotics. Bacterial endocarditis has about a 100% mortality if you don't treat with antibiotics, down to 25% with antibiotics. And even skin infections had about an 11% pre-antibiotic mortality rate, down to less than 0.5% with antibiotics. And by comparison, treatment of myocardial infarction with aspirin or streptokinase results in about a 3% change in mortality. So clearly, antibiotics are incredibly important medications, drugs for the maintenance and treatment of infections and disease in human health. Next slide. And antibiotics really have allowed successful development of many areas in modern medicine. So not only are they used to treat sepsis, but they're used for prophylaxis of many surgeries, including very common surgeries that we consider quite safe now, like cesarean section or prosthetic joint replacement. And none of those sorts of infections would be possible unless we had antibiotic prophylaxis, or would be as safe, I should say, unless we had antibiotics to use for prophylaxis. Antibiotics allow us to support patients who have chronic conditions like diabetes mellitus. They allow organ transplants. They allow dialysis for advanced kidney disease. And they allow us to treat life-threatening cancers with myeloablative and highly immunosuppressive therapies, because antibiotics can support and treat patients during the periods where they're extremely vulnerable to bacterial infections. Next slide. So the golden age of antibiotic development was quite some time ago, between about 1934 and 1968, when 14 classes of antibiotics were introduced. Next. But this has really declined over, and I know you've all heard this, over the last really 35, 40 years. And in the last decade, only 2 new classes of antibiotics were released anywhere on the globe. And we also have this inexorable emergence of antibiotic resistance. So on average, it has taken about 8 years for antibiotic resistance to be detected clinically once a drug, an antibiotic, is in clinical use. But this can range, time can range anywhere from a few months for a drug such as methicillin, up to more than 30 years for vancomycin. But eventually, it always occurs. And so where does that leave us now? Well, this is a very nice systematic analysis published in The Lancet in 2022. And the authors estimated that the global burden of antibiotic resistance in 2019 included nearly 5 million deaths associated with antibiotic resistance and 1.27 million deaths attributable to antibiotic resistance. And this is across the globe. And as is often the case, unfortunately, in our world, low-income settings bore the brunt of the morbidity and mortality due to antibiotic resistance. Next slide. And antibiotics resistance is a very costly threat. This figure is taken from a study done by the UK Health Department and the Wellcome Trust. And they estimated that by 2050, there will be 10 million deaths attributable to antibiotic resistance annually, costing the world economy about $100 trillion in lost global productivity. And as you can see, the majority of those deaths are predicted to occur in Africa and in Asia. Next slide. So what can we do? Well, we do have tools. And I think in particularly the 10 or 15 years before the COVID pandemic, we've really made some really good progress, at least here in the United States, on reducing antibiotic resistance. So the tools that we have available and that have been used with some success include antibiotic stewardship, so both human and animal. We have to remember that antibiotics are used not just in healthcare, but in the community, in veterinary medicine, and in particular in agriculture. And all of these, this interplay between all of these different systems is really important in driving antibiotic resistance. We also have infection prevention measures, and these in particular, I think we really optimized during this 10 or 15 years before the pandemic started. And these were things like very basic measures: hand hygiene, barrier precautions, decolonizing patients, etc. You can read those here. And then finally, rapid diagnostics. But it's really this middle group that I wanted to focus on for a minute and show you some examples of success that occurred, again, just pre-pandemic. So next slide. So one sort of general approach that was taken were these regional collaborative quality initiatives. And the first and probably perhaps the best known was this Keystone ICU project, which was done in Michigan. It included 103 ICUs in Michigan, and they introduced a bundled intervention, including a checklist to try to reduce catheter-related bloodstream infections in ICUs. And this bundle included, again, very basic, elemental patient safety science training of physician and nurse leadership in these units, and then development of a checklist that included things like making sure that the person who put the line in had washed their hands, that they used a full drape, that they avoided the femoral site, that they removed the catheter when it wasn't needed. So really things that are now standard of care, but at this time were novel. And this intervention resulted then in reducing central line associated bloodstream infections from about 7.7 per 1,000 catheter days down to about 1.4. So this intervention was successful. And again, reduced infections will result in reduced antibiotic use, should result in reduced antibiotic resistance. So this had an indirect effect then on antibiotic resistance, or predicted to. Next slide. I'm sorry, yeah, next slide, or move forward. Thank you. So, and this is a more contemporary approach. Again, another regional quality collaborative. This again occurred in Michigan, now 46 hospitals. And this initiative was aimed at reducing unnecessary antibiotic treatment of asymptomatic bacteriuria, or ASB. And they had, again, a bundled approach. They used collected data, because again, you can't fix what you don't measure. So they collected data, they shared best practices, they benchmarked performance, and they did this over about a 3-year period. And they found that the percent of patients with a positive urine culture and asymptomatic bacteriuria declined during this time from about 34% to 22%. But the percent of patients who had asymptomatic bacteriuria and received antibiotics remained roughly stable. And their conclusions were that it was easier to convince providers not to order an unnecessary urine culture than it was to convince them not to treat the bacteriuria once it was detected, even if it was asymptomatic and it didn't need to be treated. So diagnostic stewardship more effective than antibiotic stewardship here. And again, in this initiative, reducing unnecessary antibiotic exposure should reduce antibiotic resistance. So sort of an indirect effect. Next slide. And then there were some other studies that had both direct and indirect effects. And these were a group of studies that decolonized patients in various settings and using a cluster randomized trial approach. And this was new for infection prevention during this period and really added rigor to the before-after sort of quasi-experimental work that had been done in large part up to this point. So the first study, and again, probably the most well-known of these, is the REDUCE MRSA trial led by Dr. Susan Wong. This was 43 US hospitals, 74 ICUs, 74,000 patients. It was a 3-group cluster randomized trial comparing routine care to targeted decolonization of patients found to, or screened and found to be positive for MRSA, and then universal decolonization with chlorhexidine bathing and mupirocin in the anterior nares for all patients in the ICU, no screening. And universal colonization was found to be most effective with a reduced all-cause MRSA clinical culture rate of 37%, number needed to treat of 181 patients, and a reduced bloodstream infection rate of 44%. So again, direct effect in reducing MRSA colonization, indirect effects in reducing infection, reduced antibiotic exposure, and indirect effects in reducing cross-transmission of these resistant pathogens. Next slide. And again, a more recent follow-up to the study, a number of studies have been done, but this is the most recent one that I'm aware of, that now changed the focus from ICUs to nursing homes, which again, we know have a big antibiotic resistance problem. So this was done in California, 28 nursing homes were involved. Almost 29,000 residents, 14,000 in the intervention arm. This was a cluster randomized trial of routine care bathing versus universal decolonization, again with chlorhexidine, but now with nasal iodophor. And their primary outcome that they measured was transfer from the nursing home to a hospital. And they found that in the intervention arm, hospitalization was reduced by 1.9 per month per 100 bed nursing home. So patients number needed to treat to do this was about 8.9 to prevent one hospitalization. And the MDRO adherence rate was reduced by 30%. So again, direct effects and indirect effects that should have a substantial impact on antibiotic resistance here. Next slide. Okay, and there were trials now that have been done also in low and middle income countries. And this is very important because remember, I told you that those are the countries that bear the burden of antibiotic resistance. So this is a consortium that's funded by the NIH, and this is one of several studies they've done. So this is the CHEETAH study, and it involved routinely changing sterile glove and instruments at the time of abdominal wound closure to prevent surgical site infections. And this was a cluster randomized trial in 7 low-income and middle-income countries, 81 hospitals in Benin, Ghana, India, Mexico, Nigeria, Rwanda, and South Africa. 21-month study. And they found that the surgical site infection rate was decreased from 18.9% in the routine care arm to 16.1% in the arm in which they changed gloves and instruments at the time of abdominal wound closure. And the number needed to treat here to prevent one surgical site infection is 35.7. So this was a simple solution that resulted in significant reduction in SSI. If it results in SSI reduction, it should result in antibiotic exposure reduction. And it's broadly applicable to low, middle, and high income settings because of its simplicity and relative small cost. Next slide. So these and other sorts of interventions really resulted in some success. And this is one way that this was measured. So in the United States, the CDC in 2013 published their first antibiotic resistance threat report, follow-up in 2019. And in 2019, they found that the interventions that had been going on, that during that period of time, the number of deaths and the number of infections due to their high priority target antibiotic resistant organisms were decreased in almost every category. Next slide. Okay, but unfortunately, many of these, or most of these advances were reversed during the COVID-19 pandemic. And it really, I think the pandemic revealed the fragility of the gains that we had made and illustrated or highlighted the need for new approaches, including things like restoration or protection of a health-associated indigenous gut microbiota that might be able to resist some of these MDROs, at least those that are found primarily in the gut. So next slide. So with that, I am going to end my preliminary comments. There will be time for questions at the end of all the speakers, and I turn it back to you, Diane. Thank you.
Thank you, Dr. Hayden. As a reminder to the audience, please use the Q&A button to ask questions at any point during the presentation. Now it is my pleasure to introduce you to Dr. Vincent Young. Dr. Young is the William Henry Fitz Butler Collegiate Professor in the Department of Internal Medicine, Infectious Diseases Division, and the Department of Microbiology and Immunology at the University of Michigan Medical School. He received his undergraduate degree from MIT, received his MD and PhD in microbiology and immunology from Stanford University. He completed his clinical training in internal medicine and infectious diseases at the Massachusetts General Hospital. He was previously on the faculty at Michigan State University prior to joining the University of Michigan in 2007. Dr. Young has a longstanding interest in understanding the pathogenesis of bacterial infections of the gastrointestinal tract and the role of the normal microbiota in human health and disease. As part of the NIH Human Microbiome Project, Dr. Young led a team that studied the role of microbiome in inflammatory bowel disease. A key aspect of Dr. Young's research is translating basic research to clinical practice and observing trends in clinical care to drive the research done in the laboratory. The lab's focus on healthcare-associated infections is helping define the unintended consequences of modern healthcare related to the rise of antibiotic resistance and disruption of the microbiome. Through a detailed understanding of the interactions between the indigenous microbiota, pathogens, and the human host, The Young Lab hopes to improve our ability to treat infection while minimizing long-term adverse consequences to human health. Dr. Young, I turn it over to you.
Great, thank you for the introduction. If I can have my first slide. We're going to talk about the gut microbiome and antimicrobial resistance. Following up on what Dr. Hayden says, we have made significant gains in our ability to handle healthcare-associated infections, but we need more. We haven't driven it down to zero, and perhaps by modulating the microbiota of the gut or at other mucosal sites, we can move forward. So I'm going to bring up some concepts and mechanisms and introduce a little bit of the studies that suggest that this might be useful in AMR, but I will be using Clostridioides difficile infection as sort of my example of how we can modulate the microbiota. So next slide, please. These are my disclosures. I will not be discussing any off-label use of FDA-approved therapies. If we can go to our next slide. So our modern view of infectious diseases kind of stems from what I was taught when I was a graduate student and a postdoc. At that time, we were very much focused on the host and the host responses and how changing that, in addition to the pathogens and the virulence factors that they contain, how that tips the balance towards health or disease. But subsequently, we've had a lot of information that the indigenous microbiota, in particular at the gut, but also at other sites, can modulate this balance between host and pathogen. And that's what we'll be talking about today. Next slide, please. So just as an aside, I'd like to define how I am going to use the term microbiome and microbiota. When I'm referring to the microbiome, I'm not just referring to a community of microbes that are inhabiting a particular environment. I'm also going to be talking about the environment that they are actually inhabiting, such as the soil or the human body. And the reason for that is that this microbiome, this environment that's consisting of microbes and their surrounding milieu, that's defined not just by the microbes, but also by their host and abiotic factors such as diet. When I'm referring just to the microbes themselves, I'm going to try to use the term microbiota. So next slide, please. So as I said, we're going to use Clostridioides difficile as an example of how we can leverage studying the microbiota to come up with new ways to treat an infectious diseases. So Clostridium, or Clostridioides difficile, we know is as an anaerobe spore former that produces a toxin, a very potent toxin that causes all the signs and symptoms of infection with this pathogen. The spores are important because they are an environmentally stable reservoir for the organism. And in fact, a lot of our control measures involve removing spores from the healthcare environment. It's detected in only a small fraction of the healthy portion, something that might become a little bit more important later on in the discussion. Next slide, please. So our model of C. difficile infection really focuses on changing a normal microbiota that has the characteristic that we call colonization resistance. That is, that a stable community of microbes resists entry by other microbes, including pathogens. However, if the microbiota is disturbed, for example, by the administration of therapeutic antibiotics, we can change both the structure and the function of the microbiota to a more susceptible state. For example, if they're exposed to C. difficile spores, the spores will germinate. This will then result in the formation of the vegetative reproducing form of C. difficile that also produces the toxin that is responsible for, as I said, the signs and symptoms of infection with the pathogen. We can, of course, use more antibiotics directed against C. difficile to try to treat the disease. And hopefully, when we stop all antibiotics, we return to having colonization resistance from a normal microbiota function. However, we all know that many patients, about 20% of patients who have an initial episode of C. difficile infection, they'll develop recurrent disease when all antibiotics are stopped. That is, without an additional antibiotic insult. And these patients can have multiple cycles of C. difficile infection. They can lead to significant morbidity and mortality. Now, to combat this, we have come up with the idea of restoring the microbiota to restore colonization resistance. Next slide, please. And of course, some of the recent attention for this happened about 10 years ago when the first controlled trial This one case was comparing vancomycin to fecal microbiota transfer for recurrent C. difficile. Standard practice at that time was to treat with additional rounds of antibiotics, for example, vancomycin, or at the time, metronidazole, and that only had about a 20 to 30% success rate at treating recurrent disease. However, when patients had feces from a healthy individual administered, in this particular case, via duodenal infusion, the efficacy of that treatment for breaking the recurrence cycle was greater than 93%. And in fact, this trial was stopped early by the Data Safety Monitoring Board because it was thought to be unethical to continue just offering vancomycin to one arm in this trial. Next slide, please. But how does this happen? How does restoring the microbiota via feces actually work? First of all, are we actually replacing organisms? This is a paper that we published almost 10 years ago as well, where I had a postdoctoral fellow, Anna Seekatz, who was looking at samples that we obtained from colleagues in Minnesota who had been treating patients with recurrent C. difficile by fecal transplantation for quite a number of years. Next slide, please. And the details are in the published paper. But basically what we showed, to make a long story short, that we were able to transfer microbes from patients who had a normal gut microbiota, and in this particular case, those samples are indicated in blue on the heat map over there, compared to the patients who had the recurrent C. difficile in red, which had a less diverse. In other words, it looked like it had been exposed to many rounds of antibiotics. Not as many organisms are there. The organisms that are present are not the ones that are found in healthy individuals. And indeed, when we did treat patients with fecal microbiota transfer, there was a transfer of the community structure. However, and the details again are in this paper, the structure does not predict function. There were 2 patients that failed, and we could not predict that based on them having a lower diversity microbiota after fecal transplant. Next slide, please. So how does this happen? How does transferring microbes actually transfer colonization or restore colonization resistance? So there are a number of potential mechanisms. For example, the microbiota can compete for nutrients, perhaps starving C. difficile or converting them to more toxic metabolites such as short-chain fatty acids, which are shown to be inhibitory to C. difficile. They can modulate host metabolites such as bile acids. And this is why I use the term microbiome, because the bile acids don't come initially from the microbes, but from the host. And we'll talk a little bit about how bile acids affects C. difficile metabolism. Other microbes can directly produce antimicrobial products such as bacteriocins, or they can signal through the host, either through the epithelium or the immune system, modulating the environment, again, modulating the microbiome, for example, changing secretory IgA or other antimicrobial compounds such as antimicrobial peptides. So obviously this is a very complex situation, and how can we actually figure out what is going on in particular for C. difficile, or in the setting of AMR, how can we limit an antimicrobial resistant pathogen? Next slide, please. So looking at specific mechanisms, a different postdoc, Casey Terrio, who's now at NC State University, wanted to just look at the metabolome. In other words, all the metabolites present in a mouse model of C. difficile infection. What does antibiotics do to shift the microbiome? In particular, looking at the metabolites that are present in the gut. Next slide, please. So to cut a long story short, that this was an untargeted analysis, but what came out of it is that there was a focus on bile acids, because bile acids seem to be associated with colonization resistance in our animal models, and subsequently we have shown this in human patients. And what you find here is that bile acids are produced by the host in the liver. They're conjugated to glycine and taurine. And these primary conjugated bile acids are actually potent germinants for the C. difficile spores. In other words, the C. difficile spores can kind of sense that they're in the gut when they detect bile acids such as taurocholate. Now, that's not the whole story there. again, looking at the concept of the microbiome, this actually reflects the combined metabolism of the host and microbes. For example, there are some microbes that can take through the activity of biosalt hydrolases. They can remove glycine and taurine, releasing the primary unconjugated bile acids. Still other microbes can carry out a multi-step 7-dehydroxylation activity, producing a whole variety of secondary bile acids, for example, deoxycholate. And let's just focus on deoxycholate. It is a weak germinant for the C. difficile spores, but Casey also showed, and in subsequent work has extended on this, that deoxycholate is highly toxic to vegetative C. difficile. So what happens when we remove all the microbiota-mediated metabolism or significantly alter it through antibiotic administration? Well, one of the things that will happen is you'll accumulate taurocholate, and that is the potent germinant. At the same time, you will decrease the levels of deoxycholate, which works against the vegetative C. difficile. So therefore, the microbiome in an antibiotic-treated individual can be made to be much more conducive for not only germination, but outgrowth and eventual toxin production by C. difficile. Next slide, please. So it's been looked at, both suggested by Joe Sorg when he was a postdoc with Link Sonnenschein, that organisms that could restore bile acid metabolism, such as Clostridium scindens, could actually help restore microbiome function. And in this particular case, we're talking colonization resistance against C. difficile. Eric Paymer and his group, using a bioinformatic approach, came up with the same conclusion. And they showed, again, that Clostridium scindens, if they administered it in a mouse model of C. difficile infection, they could restore colonization resistance. And this was associated with restoring bile acid metabolism to a more baseline normal state. Next slide, please. So we now are using FMT to treat recurrent C. difficile. This will be gone over a little bit more in the next talk. But what we're trying to do now is moving from fecal microbiota transplant, or where we just take feces, be it from carefully screened donors, or in the initial case, we used to use domestic partners. We now have purified or processed fecal material. Dr. Safdar will talk about some of the ones that have received FDA approval over the past year. People are trying to move past that because feces is really not a defined product. A number of groups are trying to come up with defined consortia of cultivated microbes that are being used to treat recurrent C. difficile. Or in some cases, they're trying to come down to a single microbial agent. The VPI 20621 is actually a non-toxigenic C. difficile strain that has made it through phase 1 and phase 2 trials. And people are also trying to say, well, we don't have to use live organisms. Why don't we use things like bile acids or short-chain fatty acids or bacteriocins and actually come up with microbial metabolites that can be used to treat recurrent C. difficile infection? Next slide, please. But what about antibiotic resistance here? We recently, a postdoc and I recently published a paper, well, actually it's in press right now, where we kind of examined what is the relationship between the microbiome and antimicrobial resistance. And the work in this area has come in two major lines of investigation. There have been animal studies. Eric Paymer's group, again, has looked in mouse models and showed that fecal transplantation could eliminate colonization with vancomycin-resistant Enterococcus or carbapenem-resistant Enterobacteriaceae. And then there are some human observations. This will be gone over more in the next talk. But it was noted that when patients were having fecal microbiota transplant to treat recurrent C. difficile, that also reduced the frequency of recurrent urinary tract infections in these patients. And it was also noted this would decrease the antibiotic resistance that was seen during breakthrough UTIs. Next slide, please. So there are a number of case series, and on this particular slide, we're looking at a retrospective case-controlled trial of FMT for AMR decolonization. In this case, they had 10 patients that they gave fecal transplant to. These are patients who were carrying carbapenemase-producing bacteria. And they noted that at At 14 days, 8 of the 10 patients who received FMT were decolonized from their CRE carriage, where only 2 of 20 at the similar 2-week time point had eliminated carriage of the FMT. This was a fairly aggressive regimen. The patients had bowel lavage times 2 and then were treated with a non-absorbable antibiotics before they received the FMT. Next slide, please. To my knowledge, the only randomized controlled trial of looking at FMT for the decolonization of antibiotic-resistant organisms is this trial that was published 4 years ago in CMI. And in this case, they used a 5-day course of oral antibiotics, and then they followed that by fecal transplantation. This was a multi-site trial. In some cases, they were given the FMT via nasogastric tube, or in some cases, it was given via encapsulated fecal material. Now, in this particular trial, there was a trend towards decolonization in the patients who received FMT. The odds ratio was 1.7, but given the fact that they didn't reach their anticipated enrollment, mostly because they found it very difficult to enroll patients here, and the trial was terminated early, the confidence interval did span 1. So it's suggestive, but did not show that FMT was able to decolonize the patients here. And again, this may actually have something to do with the variations in how FMT was administered. Moving forward to the next slide, please. Where are we at right now? Well, we do know that the indigenous microbiota can interfere with colonization by pathogens such as Clostridioides difficile, but there's also suggestive evidence that multi-drug resistant bacteria such as CRE or VRE can also be treated by modulating the microbiota. So we're still in the early stages of using so-called microbiome therapeutics for treating multi-drug resistant organisms. We really don't know the appropriate methodology. For example, initially, when people were using FMT for C. difficile, they would take a fecal specimen, they would put it in water or sterile saline under ambient O2 in a Waring blender and mix it all up. And therefore, since 99+% of the microbes that are present in feces are actually anaerobes, they killed them all off. Subsequent work has shown that the spore formers that are resistant to that kind of treatment are sufficient for treating C. difficile infection, but there's no reason to think that that will be true for things such as VRE or CRE. And given the fact that we're kind of lumping multi-drug resistant organisms together, they have quite different physiologies. So again, just kind of saying that, well, the thing that works for C. difficile infection will work for VRE or MRSA or multi-drug resistant Pseudomonas or Enterobacteriales is probably a little bit naive. And so we really do actually have to do a lot more work to figure out precisely the manner in which we can modulate the indigenous microbiota to eliminate these particular organisms. So next slide. So I thank you for your attention. We will be taking questions at the end, and I'll turn it back to you, Diane. Thanks.
Thank you, Dr. Young, for your presentation. Now I'm pleased to introduce you to our final speaker, Dr. Nazia Safdar. Dr. Safdar is a professor in the Division of Infectious Disease with the Department of Medicine at the University of Wisconsin School of Medicine and Public Health, where she is also Associate Dean for Clinical Trials and Research Director of the Wisconsin Medicine Institute for Clinical Trials. Dr. Safdar is a Faculty Director of Investigator-Initiated and Multi-Site Research, Institute for Clinical and Translational Research. Dr. Safdar serves as the Associate Chief of Staff for Research at the William S. Middleton Veterans Hospital and as the Medical Director of Infection Control at UW Health. Her research aims to reduce and prevent healthcare-associated infections by identifying, testing, and implementing novel interventions. Because of her work and research in this area, in 2017, Dr. Safdar received a President's Early Career Award for Scientists and Engineers, the highest honor bestowed by the U.S. government on outstanding scientists and engineers beginning their independent careers. In 2018, she was the recipient of the NIH Director's New Innovator Award. In 2019, she received the Oswald Avery Award for early achievement that honors IDSA fellows aged 45 or younger for overall outstanding achievements in infectious disease. In 2021, Dr. Safdar became an invited fellow of the Alpha Omega Alpha Honor Medical Society and an American Society for Microbiology Distinguished Lecturer in 2023. Dr. Safdar, welcome. We are thrilled to have you present next.
Thank you very much for this introduction. Good day, everyone. Appreciate you all being with us today. So I'm going to be expanding on Vince's talk a little bit and talking about therapeutic and preventive measures that harness gut microbiome modulation to combat AMR. Next slide, please. And the objective of my session will be to identify potential therapeutic and preventive measures, and we'll talk about that going forward. Next. So the two that you all may know that have received FDA approval in terms of live biotherapeutic products are VOWST, also known as SUR-109, which is the purified live firmicutes oral spores product, and then Rebiota or RBX-260, as it was known when it was in clinical trials, which is a broad consortium of microbes delivered by Anima. These are significant advances in our management of CDI. Next. So for SUR-109, the advantages are that it's an oral microbiome therapy. It's given once a day as 4 capsules over 3 days. And in this phase 3 randomized control trial, the primary endpoint was recurrence of C. difficile infection within 8 weeks. And as you can see on the bottom half of this slide, that about 89 participants received SUR-109, 93 received placebo, and the recurrence rate was 40% in the placebo arm and 12% in the active treatment arm. And so this was really the first time that we had quite a dramatic achievement shown in this RCT proposed clinical trial, and that then subsequently led to FDA approval. It is important to recognize that given that these are patients that have been treated for recurrent CDI, and then following that treatment and symptom management, now they're being given SUR-109 for prevention of future recurrence, there is the need to give magnesium citrate to those patients so that any residual antibiotic effect can be mitigated and that the microbiome therapy can actually have its full effect. Next slide. These are the demographic and clinical characteristics of these patients. You can see that it was about half and half distribution between less than 65 years and 65 and older. There were slightly more female participants and overwhelmingly white participants in this trial. There was also a good mix of the number of episodes of C. diff, whether they were 3 or more than 3. And even though they had a mix of both oral vancomycin and fidaxomicin as the treatment for the C. diff episode, there was far more oral vancomycin used than fidaxomicin. And so some of the other endpoints that were of interest in this trial was, as I mentioned, the dramatic decrease in the recurrence, which was the primary endpoint, but they also looked at a different alternative metric, sort of the reverse of the recurrence, which is the sustained clinical response in people that did not have recurrence. And you can see there also the active treatment performed much better than placebo in producing sustained clinical response. There were some stratified analyses done looking at by age and whether the initial antibiotic for treatment was vancomycin versus fidaxomicin. And in both those stratified analyses that you can see at the bottom of the slide here, the active treatment outperformed the placebo, which also gives us options then when thinking about the differential effect of this in, say, older versus younger population, or whether the initial antibiotic is vancomycin versus fidaxomicin. Very few participants received fidaxomicin, as I mentioned. The other agent that is a very different approach to this is a single dose of this live microbiome product administered by Anima. And in this trial, they found a 13-point treatment difference between placebo and between RBX-2660. The primary endpoint was also success at 8 weeks, and they also followed patients for up to 6 months to determine if they remained free of C. diff recurrence. Next slide. Some of the things to think about for this one is also that there was a wide array of C. diff recurrences. Patients either had more than one recurrence of C. diff episode after a primary episode or more recurrent CDI than that. The treatment arms were a single dose of the Anima product or placebo, about 180 participants in the treatment arm and 87 in the placebo arm. And the primary endpoint was C. diff recurrence at 8 weeks. The microbiota suspension is a broad consortium of live microbes, which is sourced from healthy donors. Next slide. And most of the adverse events that occurred were fairly mild to moderate, and in general, when this has been given in clinical trials, this has been pretty well received and well tolerated by participants. I think some of the things that we think about when we review the results of these clinical trials is what diagnostic test was used for C. diff. In situations where the PCR has been the sole assay used to determine whether recurrent C. diff has occurred or not, there can be the risk of overdiagnosis and overcalling the endpoint. And so for many of these trials, it's usually a combination of obviously symptoms plus PCR plus either a second test or an independent adjudication. And so I think those are the things that are important here. There's also this consideration of how one would implement such a treatment program, with one being oral and the other being enema requiring and a place where this could be administered by a healthcare professional, which comes with its own considerations and sometimes limitations. Next slide. Now, moving on from C. difficile infection to urinary tract infections, this is one study that Vince also mentioned, which is if we can reduce C. diff using FMT, is there the potential to also make an impact on urinary tract infections? Next slide. And this was a retrospective study. There was a chart review to identify patients who had had several UTIs in the year prior to FMT, and they also had recurrent C. diff. So a pretty unique, small niche population. The controls were patients who had had several episodes of C. diff and had had multiple UTIs, but had not received FMT. In this case, the FMT was introduced via colonoscopy, and the UTI required the patient to be symptomatic and have a positive urine culture with a pathogen typical for a urinary tract infection. There was no microbiome data that was available to analyze in this study, and there was no statistical adjustment either for baseline differences or following to see whether there were any confounders that explained this relationship between the FMT and UTI. And so it was a univariate analysis that was performed. Next slide. But with all these caveats, what they did find was that in people that had, so the top half of the slide are the cases. Before FMT is a light gray, and in black is after FMT. And you can see as you move from, the numbers just represent the number of the participants, or each bar represents one patient. And you can see that there were far fewer UTIs in the after FMT side of things than there were in the before, which was not the case with the controls, which had several urinary tract infections even after. Next slide. So this makes us think that there is potential for FMT and UTI, but given all the caveats that have already been discussed, I think that it's the sort of thing that can be considered intriguing at this point, but needs a lot more attention and study before one would declare it ready for that indication. Similarly, for FMT decolonization for vancomycin-resistant Enterococcus, this was a multi-center retrospective study. If we go to the next slide, where they examined how patients with VRE were decolonized with FMT, which was delivered either via allogeneic FMT or in some instances by autologous FMT. The same limitations apply here, that the patients all had recurrent CDI, which was their main reason for needing FMT. And as an incidental co-colonization, they also had VRE. So none of these studies have really looked at when the colonizing pathogen, either for VRE or for a UTI, is the sole pathogen in question. And what they found was that with the allogeneic FMT, which is on the right lower part of the slide, colonized with VRE was much lower with both of those, and then at 6 weeks as well. Again, I think very preliminary data that supports the rationale to continue to pursue this line of inquiry in a more rigorous manner. But in general, I think a lot of unknowns at this point still. Next slide. One thing I'd like to mention is what a very interesting abstract that was discussed at this year's ID Week, which looked at disparities in FMT treatment. As we talked about, there's a considerable number of things to think about when we're implementing an FMT program, regardless of the type of product that is eventually selected and implemented. In this study, they looked at CDI surveillance that was being done in 8 metropolitan Atlanta counties. They looked at incident CDI, so a toxin assay or a molecular assay. between 2016 and 2019. And these were categorized as either single episode of CDI or a recurrent episode of CDI. And they had over 13,000 residents in these counties with C. diff, 22% with recurrent, and 1.8% had an FMT for C. diff. Next slide. And what they found was that when they also looked at the social vulnerability index based on where the individuals lived, and they found that housing type and transportation was a predictor for recurrent C. diff. And it was also one of several factors that was predictive of not receiving FMT, which leads us to think about problems with access to care and timely access to treatment. But the most vulnerable patients in housing and transportation were also more likely to have recurrence, which again speaks to maybe access to care for initial treatment of C. diff, or lack of follow-up, or inability to afford the medication. We know the costs of fidaxomicin are substantial, for instance. Next slide. And the independent predictors of FMT receipt included younger age and female sex. But the concerning finding here was that patients living in a largely minority census tract were 37% less likely to receive an FMT. And unsurprisingly, those that were in a largely uninsured tract were 39% less likely to receive an FMT. These disparities are not unique to FMT, but in the infectious diseases world, when we now have treatments that have the potential to change the landscape of C. diff recurrence, I think we should pay a lot more attention to inequities in access to effective treatment. Next slide. And also, unsurprisingly, more socially vulnerable populations defined by access to transportation and level of household crowding were more likely to develop RCDI, and then also less likely to receive FMT, particularly if they were uninsured. Next slide. So to summarize, we now have 2 FDA-approved options for management of recurrent CDI. Institutions will determine among themselves what the best implementation plan is to put one or both of these in place. And I think while they're doing that, we should make it a point to focus on equitable access for our populations. While there is intriguing data on the possibility of reducing UTI and potentially VRE colonization with FMT, obviously we cannot draw any causal inferences from what already exists. And I think a lot more attention has to be paid to clinical trial design and interventions before we move that forward. Thank you very much for this gift of your time. I'll turn it back over to you, Diane.
Great, thank you, Dr. Saptar. Now I'd like to make sure all the speakers are unmuted and back on screen for the Q&A portion of the webinar.
All right, thanks. So we have several questions in the queue here, and I think one for Dr. Saptar. Audience member asked about biomarkers to predict conditions where AMR may be particularly open to microbiome intervention. So this is like the holy grail of the microbiome disruption index, I think, that we'd all like to see. But you touched on that a little bit, Nancy. I don't know if you want to make some more comments.
I think that is the holy grail. I don't think we're quite at the point where we can say that a particular signature will predict either, say, if we take the example of C. diff, will predict recurrence or success or duration of treatment. And I think it may well be that given the variation in the human microbiome, it may be that there isn't that precise biomarker that exists that would apply to all. I think part of the challenge is that in the studies that have addressed the microbiome, there hasn't been a lot of attention paid to the host. And it's really what the microbiome does within the host that is probably equally important. So for future studies of biomarkers, we need both aspects of this to be studied.
Thank you. So, and that sort of leads into the next question that maybe we can ask Dr. Young, Vince to comment on, and that's a question somebody asked how an antibiotic-induced C. diff infection disturbs the gut microbiome differently than an autoimmune condition that affects the gut microbiome.
Yeah, that's an interesting question. We always joke that no matter what you do to someone, it'll alter their microbiota. But I'm going to flip it around a little bit, because autoimmune conditions can affect the gut microbiome in a way that actually makes them susceptible to C. difficile infection. And one that we have studied is that patients with inflammatory bowel diseases, ulcerative colitis and Crohn's disease, they're more likely to get C. difficile infection, and also when they get a C. difficile infection, that can actually trigger a flare of their disease if they're in a quiescent phase. So we recently published a couple of papers, again, in mouse models to show that just triggering inflammation on its own will alter the microbiota in such a way that without antibiotic administration, these animals are susceptible to colonization with C. difficile. So it is pretty complicated. I brought up that picture of the microbiota, the host, and the pathogens, and they all affect each other, and that whole system can get disturbed when any one of the three members has been altered. So I think I can leave it at that.
Thanks. And then Dr. Young answered one, or Vince answered one question in the he typed a question or an answer in the chat, but I wanted to comment on that too. So this is questioner asked about whether or not it's unreasonable to consider development of live bacterial products that are intentionally resistant to antibiotics, such as a vanc-resistant, fidaxomicin-resistant consortia for CDI. And I think you can read his response there, but I think this is a question when we talk about trying to use these products for treatment of antibiotic-resistant organisms. It's different than C. diff, because as Dr. Young points out, for C. diff, typically we use them after we've completed some sort of antibiotic therapy to treat the C. diff specifically, and then we try to restore the gut microbiota. For antibiotic-resistant organisms, oftentimes we're trying to protect them, or maybe the goal is to try to protect them during periods of vulnerability. So if you have ICU patients or cancer patients, for example, and somebody asked about hematopoietic stem cell transplant patients, you're trying to protect them to keep the either protect them from colonization with these resistant bugs, or keep the concentration of the resistant bugs, the relative abundance of these resistant bugs low enough that the patient doesn't suffer from invasive infections. And those patients oftentimes need antibiotics during that period. And so and if we're giving them a consortium that's very sensitive to antibiotics, there could be a problem there theoretically, correct? So I think that is an issue. Personally, I would not want to try to develop these very resistant C. diff colonizing strains and give them to patients, but I don't know if Dr. Safdar has a final comment for us there.
No, I couldn't agree more. I think this does need to be carefully considered because, of course, there's the collateral damage and the collateral consequences for every intervention, including microbiome manipulation. Just because we can do it doesn't mean we should.
Oh, and there's a question here, I guess, about is there a role for decreasing toxin production using, well, this is more antibiotic therapy, but using linezolid complementing other treatments such as fidaxomicin or vancomycin. I don't know if either you, Dr. Safdar or Dr. Young, have any thoughts about that.
I was actually typing in the response, but I'll just kind of say it quickly. I mean, I think this is a reasonable approach. This is something that's been proposed, for example, when we're treating other toxin mediated diseases. It hasn't been tested carefully as far as I know, and it should be noted that the use of televimir, the bile acid, the toxin binder, was shown not to have any increased efficacy in a clinical trial where they use that to try to sop up the toxin. Now, is that different if you were trying to limit the production of toxin? Perhaps, but I don't know if people would be wanting to go that direction right now.
Thanks. So maybe the last question I'll ask Dr. Safdar, since you again touched on this a bit in your talk. And the question is about studies of microbiome therapeutics and other anti-infectives in development for recurrent CDI. And those trials that are skewed to white patients. So do patients of color not get CDI, or are they not offered a chance to participate in clinical trials? It's a big question.
Yes, no, thank you for that question. I think that it's probably a combination of access to care, because most of these trials are coming into the health systems. And so it's that health system population. And is there adequate outreach to give people a chance to participate? The literature on this suggests that there are biases at play literally at every step. So for instance, from the standpoint of introducing the study to a subject, even before the PI or the research coordinators enters the room, they may already have assumptions about whether this would make a good participant, for instance, or not, whether they would be able to come back to follow-up visits. And so oftentimes, some of these biases play out in the clinical trial not being even offered as a possibility. I think this needs a lot of intentional work. And I think the FDA new standards for requiring that patients to whom the results will be applied should be part of these trials is a good step in the right direction. I also think that for years, and it may still be the case, that mistrust is a player here where patients may not want to participate. But I think overall mistrust is not the primary reason why patients of color don't participate. It's that they're often not offered the opportunity to.
There is the first question there. I don't know if anyone wants to pick that up about the hematopoietic stem cell transplant patients.
Yeah, we can. I think I was wondering, that came in very early, if that was sort of answered during your and Nasia's talks. But there's a question about this idea that in addition to C. diff, that hematopoietic stem cell transplants and other populations can have increased relative abundance, or sometimes referred to as dominance, of these bad bugs, Enterococcus or Enterobacterales, that puts them at risk of invasive infection and also cross transmission. And so the question is, are you aware of interventions that will reverse these microflora changes? And I think, again, both you, Vince, and Nasia have touched on that, but I don't know if you have something else you'd like to state.
Well, I mean, there is a trial that's being done by some colleagues at Memorial Sloan Kettering Cancer Center, where they're actually giving sort of autologous FMT. In other words, they harvest feces from the patients before they go through their conditioning regimen. The data still aren't out there yet, though, to really say if it's going to be efficacious or not. So.
Okay, so I think we got through everything. Diane, I see you back. So now I guess we are over.
Great. Thank you so much. And thanks again to Drs. Hayden, Young, and Safjar for your presentations. The IDSA Foundation appreciates your commitment and time. Thank you to our audience for your attendance and participation in the Q&A session. If you wish to revisit this webinar or share it with others, a recorded session will be made available to you via email and on our website and YouTube channel. We hope you will join us on Thursday, December 7th for the final webinar in the 2023 Dr. John G. Bartlett Memorial Education Series, titled From Awareness to Action, Utilizing the Latest Diagnostics to Eliminate Hepatitis C. The link to register is in the chat. We post about our past and upcoming webinars on our social media channels, so please take a moment to connect with us there. If you are interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit the IDSA website. And finally, we kindly ask you to consider furthering your support of the IDSA Foundation with a personal donation. Your gift plays a pivotal role in advancing our mission of workforce development and making a tangible impact in the field of infectious diseases. Thank you again, and have a wonderful rest of your day and enjoy the upcoming holiday. Thank you.